Hi there, I'm Matt Reed and I'm the Chief Investigator of the Aspired study.
And hi, I'm Nikki Freeman and I'm the lead research nurse for the Aspired study in Edinburgh. So Matt, tell us how the Aspired study came about.
Well Nikki, the Aspired study is all about patients who suffer syncope, which is a sudden loss of consciousness or blackout. And we know that about 1 in 10 patients who come to the ED have an underlying cardiovascular cause for their syncope episode. However, most of them have recovered by the time to get to the emergency department, and the only way really to capture the underlying cause is to get an ECG during their symptoms.
Okay, so it sounds like diagnosis can be quite challenging. How are these patients with unexplained syncope currently managed?
So at the moment, standard care follows NICE guidelines, which either involves inpatient monitoring or outpatient follow-up with application of a Holter monitor. And sometimes patients go on to get an implantable loop recorder several months afterwards if their symptoms haven't recurred.
So it sounds like for those options, there can be quite a time lag between when they have their episode of syncope and when the cardiac monitoring begins.
Sure, for some patients it might be several months before they have any monitoring.
Okay, but I thought the current evidence, including from your pilot study, suggests that we stand a much better chance of capturing culprit dysrhythmia if we apply the monitor as soon as possible after the syncope event. And so also if we're monitoring for a longer period of time, we stand a better chance of capturing it.
Yeah, that's right, and that's why the BHF has funded the Aspired study, which will trial the immediate application of an enhanced ambulatory ECG monitor. And we're going to compare this to standard care options that are currently available using a randomised controlled trial over multiple sites.
So can you tell us what exactly the enhanced ambulatory ECG monitoring involves?
Sure, yeah, well it involves the application of an ECG patch monitor which can be easily placed in the ED, which is unlike an implantable loop recorder which needs to be have a surgical procedure to insert it. And the patch monitor is worn by the patient for 2 weeks, and throughout those 2 weeks they can go about their normal activities and they can shower and exercise, and it provides a continuous recording of their heart during this time.
Okay, so it sounds very patient friendly and also potentially increases our chance of capturing these dysrhythmias. Am I right in saying there's already some patches on the market already?
Well, currently we don't know whether monitoring patients early, immediately after their episode from the ED and for a longer period makes any impact to diagnosis and diagnosing patients earlier and being able to treat them earlier. And importantly, we still need to ascertain whether this helps us to reduce the number of syncopal episodes that a patient experiences, which we know from all our PPR work is an important patient-centred outcome, which is what this trial is all about.
Okay, so what kind of sample size would you need to be able to show this?
So we want to recruit 2,234 patients, and we're looking to recruit them from 30 sites across the UK.
Oh, wow, that's a lot of patients. So as well as having unexplained syncope after their initial ED or AMU admission, what other kind of criteria are you looking for?
So the patient needs to be 16 or over, and they mustn't have an obvious underlying cause for their syncope, for example, pulmonary embolism, and also they mustn't have an obvious vasovagal or postural hypertension as the cause. And we know that commonly we think a patient may possibly have vasovagal within the differential, but we're only excluding patients who have an obvious diagnosis of vasovagal, which will define the protocol, and also obvious postural hypertension. So those unexplained patients who we can't definitely say have vagal or postural hypertension, we're looking to include in the study.
Sure. I'm just thinking for our research team, we don't always work weekends or overnight, so surely we might be missing a lot of patients there.
So the research team will randomise patients to either the intervention arm, which will be the 14-day ambulatory heart monitor, or to standard care, which in most patients will be either inpatient monitoring or a Holter monitor.
Okay. And if the patient is randomised to the intervention arm, after they've worn the patch for 14 days, what happens next?
So once they've worn the device 14 days, they then return it in an envelope, which it goes back to the company. The report is then downloaded onto a dashboard which the local study team can download, and then they can pass that to the relevant treating clinician for them to action whether that's the admitting consultant, whether it's a cardiologist, whether it's a specialist syncope clinic, but obviously we don't expect all sites to have that. It might just be an emergency department return clinic, for example.
And how are we comparing the trial arm, which is the 14-day ambulatory monitor, with standard care?
So yeah, patients will receive an automated text or email, whichever they prefer, which asks them a couple of simple questions, including how many episodes they've had in the previous month. And they also have a questionnaire at 1 and 2 years, which is looking at healthcare utilisation and satisfaction, but that's all delivered by the central stock team. We're looking for sites to recruit about 6 to 8 patients a month, so around about 2 patients a week.
Okay, great. And is there any other support with the project?
Whilst we ask that the local study team extract health utilisation data at 90 days, 1 and 2 years, the other follow-up is all done by the Central Edinburgh team.
Brilliant.
There's also a £100 per patient fee for patients recruited to study, and as the study is on the NIH Health portfolio, then sites will also be able to access CRN, local research nurse support.
Wow. I may be biased, but this sounds like an amazing project. When are we looking to start?
So the study itself has started, the funding from the BHF has started, and we're in the process of getting ethics, which we hope to get by October, and we're hoping to recruit the first patient by March 2022.
Brilliant. And for people out there, how can they get involved?
So either email, tweet or call us at these links, speak to your local medicine, care of the elderly, cardiology and syncope leads, and
Join the Aspire team!